So here is our last clinical correlation, pacemakers. And for this section, I just want to do a quick quiz on what chamber the pacing is coming from. So each one of these is a paced rhythm, and I want you to decide what chamber is the pacing coming from. So here's our first one. Okay, so the answer here is biventricular. So it's pacing from the right ventricle and the left ventricle. And sometimes you don't specifically know which lead, whether the left ventricular lead, which is in the coronary sinus, if that is pacing first, or if the right ventricular lead is pacing first, or maybe they're firing at the same time. But there are a couple things in the ECG that can give you a clue. So the first thing is that lead 1 and 2 and foot are all negative. So what this says is that we're pacing from the left apex of the heart. And really the only lead that originates at or near the left apex of the heart would be a left ventricular lead. And the only time a left ventricular lead is placed is when there's a concurrent right ventricular lead, because this is biventricular pacing. So the answer is biventricular pacing here. Now you can see in lead V1 that there is a right bundle branch pattern, which means that there's a wide, tall R wave in lead V1. And so when you're pacing from a chamber, whatever that opposite chamber bundle branch block, that's essentially where you're pacing from. So just to make that a little bit more clear, if you have a pacing spike followed by a right bundle branch pattern, that means that you're pacing from the left ventricle. Let me say that again. If you're pacing and you have a response that's a right bundle branch pattern, that means that you're pacing from the left ventricle. So the answer here is biventricular pacing. Okay, here's our next one. Okay, and the answer here is we're pacing from the right ventricle. So notice this ECG is quite different than the last ECG. When we have a pacing spike, we have the response is a QRS, which is a tall R wave in lead 1 and AVL. So that means that after you're pacing in the heart, the vector goes towards the left shoulder. And 2, 3, and foot are negative, meaning it's coming from the apex and going up to the base of the heart. You'll also notice that V1 is different. You'll see a very deep S wave, which is associated with left bundle branch block. So remember, before we said that if you pace and then you get a bundle branch block pattern, then that is the opposite of the chamber you're pacing from. So in this example, there's a pacing spike in V1 and then a left bundle branch pattern. So the opposite of left is right, so we're pacing from the right ventricle. How about this one? And the answer is right atrium. So this one's pretty easy because we have a pacing spike, and then we have a little P wave after that, and then a PR interval, and then a narrow QRS. So we're pacing from the atrium, and then basically it goes through the AV node, and then on into the ventricle. And one of the ways that we can tell it's atrial pacing is not only is that there a P wave response to the pacing spike, but there's also a narrow QRS, so that means that we're not pacing from the ventricle, because if we pace from the ventricle, it would be a wide QRS. Now, why is it right atrium and not left atrium? Well, the simple fact is that because we put these pacemakers endovascularly from usually the superior vena cava, and occasionally from the inferior vena cava, is that it naturally goes into the right atrium. That's our easily most accessible site, so the vast majority of these are pacing from the right atrium. And we don't really put pacemakers in the left atrium unless there's a significant abnormality in the heart or some other reason that we must rarely pace the left atrium. So it's usually the right atrium. And then the last one. And look closely here. In all the leads, look closely. And the answer is the right atrium and the right ventricle. So you can see atrial pacing spikes, and most clearly you can see that it's in lead 2. And then the QRS is a little bit wide here, and so you think, well, okay, could there be pacing in some other chamber, right? So you can see pacing spikes for the ventricle. The easiest place to see this is in lead V2, and so you can see a pacing spike preceding each QRS. And so we're essentially having atrioventricular sequential pacing. First pacing in the atrium, and then pacing in the ventricle. And usually we place these for patients with AV nodal block, where the patient can't get an electrical signal through the AV node, so you have to independently pace the atrium and then pace the ventricle.